Another important acknowledgement I would like to add is simply a thanks to all of you as participants. CanPath is what it is only because of you, and we are delighted to share the journey, this very distinctive and important journey about advancing evidence about the novel things that modern science has continued to find to be difficult to address, all of which is now more possible because of your participation than ever before. There are many thousands of participants on this call from across Canada, and we're very grateful for each and every one of you. And also, it's important to know that we are on the same journey, sharing a vision and mission and commitment to improving the health of Canadians now and in future generations. Next slide, please. I see in the chat that some of you are, next slide please, are able to see the slides now. So this will continue on. And in the chat, please continue to inform us if there's any further technical difficulty. The outline for today, you'll see we have 6 of the leaders from the regional cohorts from across Canada. We couldn't include on the program today everyone who was interested in speaking with you, but you'll see the outline of who will be speaking. I'll introduce them as we come along, and also the range of topics that we will be able to provide a high-level summary for you on today. Again, with research leaders and scientific directors from across Canada. Next slide, please. The first speaker I would like to introduce is Dr. Philip Awadallah. He's the National Scientific Director for all of CanPath, and in addition is the leader responsible for the Ontario component, or the Ontario Health Study. He joined CanPath as one of the principal investigators back in 2010, where he was the director of Cardigan in Quebec at that time, until 2015 when he came to Ontario to continue to be involved in CanPath, but taking on leadership for the Ontario Health Study. He's also the director of computational biology at the Ontario Institute for Cancer Research, and a full professor of molecular genetics and of epidemiology at the University of Toronto. So next slide, please, and I'll turn it over to Philip.
Great, thank you, John, for that introduction, and I hope everyone can hear me okay. I first want to thank you all for attending today. There's a lot happening in the world today and over the last couple of years, and so we're certainly appreciative of you attending this seminar so we can present to you CanPath. I have the role today of giving sort of the overview of CanPath, and this is effectively a presentation that will lead to some of our other leaders today presenting some of the more specific and applications of how CanPath is being used. So I'm setting the stage for them, and I'm giving you the overview of what we've been doing. And one of the things I do in setting that stage is talk to you about what are at stake and what are the issues here. Rising levels of chronic disease are one of Canada's largest public health challenges. Many people will be diagnosed with cancer, many people will die from cancer, and many people will die from other common chronic diseases. So we have many challenges in front of us, and some of the questions that we want to answer are: how do we address the root causes of health and disease among Canadians? How can we improve our health? Are there populations or communities that we need to target more directly? And how do we potentially build health systems that improve these outcomes? Next slide, please. And so this is where population cohorts are critical. Population cohorts like CanPath are long-term health studies that can offer us a chance to understand health and disease. And we're interested in not just identifying who develops disease, but we're also trying to identify with these population cohorts over time who might be coming into the cohort and develop the disease, and that might help us identify the factors associated with the development of disease. And so that's where a population cohort like CanPath differs from that, say, of a clinical study. or clinical population, clinical study in a hospital, for example. But we're also interested in who may remain disease-free. Like we want Canadians to age healthier. And so we want to identify those factors that help Canadians age better. So next slide, please. So we built CanPath to help try to address those types of questions. Today, you're going to be hearing about this from both myself and the rest of the leadership team that are able to present today. We built a population health research platform that in principle is trying to address many of the questions that I've already outlined and understand how, say, genetics, behavior, family health history, your environment impacts who develops disease and who doesn't develop disease. Almost 1 in every 100 Canadians has already signed up to the cohort. And we're really appreciative of your contributions and time. It's going to be critical going forward in terms of understanding and improving health in Canada. Next slide, please. CanPath is a partnership, and you've been probably, if you're part of the study, you've been invited through one of our regional cohorts. So as John mentioned, I lead the Ontario activity here. So you might have seen an invitation to join and seen updates from the Ontario Health Study. We are a partnership of 7 cohorts from West Coast to East Coast. Here are their names. You're going to be hearing from a lot of these leaders today. Next slide, please. And this is what makes up the over 330,000 Canadians that are part of this project. So as I mentioned, 1 in almost 100 Canadians are already part of this project. We have, in many cases, a consent to follow the health of these Canadians for 50 years or more, and we're still growing. So you see here our numbers from, say, BC, where we captured 30,000 participants. Atlantic Path has captured 36,000 participants. Quebec, 45,000 participants. Over 200,000 participants in Ontario Health Study have been recruited. In Alberta, we've recruited 41,000 participants. We're still recruiting. In Manitoba, we're still in that recruitment phase. You're going to be hearing from the leader of the Manitoba activity today. In Saskatchewan, we're just initiating those activities as well. So all provinces will effectively be covered, and we'll have a footprint, if you like, across these provinces in Canada. Next slide, please. As it was mentioned, we started this activity back in 2008, and we started under a different name. We started as the Canadian Partnership for Tomorrow Project, launched at the Canadian Partnership Against Cancer. 2008 is when we began activities in terms of baseline recruitments. Started with some pilot activities just to see how our operations would be able to manage collecting over 300,000 participants. We moved from our National Coordinating Center being at the Canadian Partnership Against Cancer to the University of Toronto in 2018, where our National Coordinating Center is for all of the provincial activities. And as of today, over 230 approved projects accessing your data have already been approved, and we've already seen over 180 publications. Next slide, please. This is just a quick snapshot of the kind of information that we've captured from the CanPath participants. When a participant is invited, the people are invited to fill out a questionnaire, and that questionnaire captures information that we wouldn't necessarily be able to capture through other means. So that captures information about behaviors, lifestyle that might be impacting health. We also invite participants to provide a blood sample. And so across Canada, the blood samples that you provided are in principle the largest biobank, if you like, in Canada as well. Those biologics enable us to do things like genomics, capture genetic information. Some participants across Canada were also invited to come to a clinical site where we were able to get physical measures. And through consent, we are able to link to other external data repositories to further enrich the information that we capture. Next slide, please. So the kinds of information that we've captured from questionnaires, and these are captured through follow-up questionnaires as well, are participant demographics, information about changes in health status, medical histories, potentially medications, anthropometric measurements, things like behaviors like sleep and alcohol usage and so on. We capture this both at what we call baseline or at enrollment, and many of you have been invited to fill out follow-up questionnaires as well. And that allows us to update information about all of these types of factors that we've captured here, that you can see here on this slide. Next slide, please. And all of this information allows us to perform what we call retrospective as well as prospective science. The retrospective studies allow us to take that information that we've collected from our participants and ask about questions like, were there factors in your life history that might have led to the development or no development of disease? Being a prospective cohort, being able to be a longitudinal cohort going forward in time, we're also able to enrich this data and determine who might also be developing conditions over time, further enriching the type of information that we're able to capture. Next slide, please. As I mentioned, we've got one of the largest biobank in the world. We've got biologics, not in the world, in Canada, sorry. We've got material stored from whole blood that allows us to do things like extract DNA and perform genomics. Over 150,000 participants have provided biologics. These are all stored in biobanks across Canada. From some participants, we've captured things like saliva and urine. And many of you, and in fact, this slide is a little outdated, have provided blood spots as part of our COVID-19 serology study, where we've actually now captured 27,000 blood spot cards from our individual participants. And so thanks to all of you for doing that. That's giving us information about antibody responses, pre and post vaccinations or pre and post COVID-19 infection. And we're inviting you to come to also give us follow-up blood spots as well. Next slide, please. One of the great things about having 330,000 participants is that we are effectively a national data infrastructure. We're more than just the activities happening in each of the different provinces. CanPath provides, if you like, a Canadian picture of health data. And with the information that you've provided, particularly for those participants that have provided a health card number, we're able to link to, say, cancer registries, other potential administrative data information that allows us to identify potential diseases that have developed that are captured in these different databases. Also, with some of the information that you've provided, we were able to capture information based on physical locations associated with things like the built environment. Do you live near? Do you live in a place considered walkable, for example, and how that might impact health. Next slide, please. So with those data linkages, we're able to do interesting kinds of science. We're able to identify, for example, individuals that have come into our cohort and may have developed a disease or a cancer. So that allows us, and you'll be hearing about this later on today, to do certain types of scientific activities where we can potentially look in our data, maybe even in our blood samples, and potentially identify, say, signatures that might have allowed us to predict that that individual might have developed that disease before they actually developed the disease. This is where we think we have a lot of strengths in the CanPath activity, is that we're able to identify potentially features that might be predictive and help therefore prevent a disease before somebody actually does develop a cancer or another chronic condition. Next slide, please. These ability to link to other data sets allow us to do things like link to major programs like the CANOE program, which is a major activity funded by the Canadian Institute for Health Research. CANOE stands for the Canadian Urban Environment Study, where we're able to identify environmental features associated with our CanPath participants that might be important with respect to health. That might include things like air pollution, noise levels, as I mentioned, greenness or walkability before. And these are critical, I think, to understanding how the environment impacts Canadian health. Next slide, please. Because of CanPath's size, 330,000 participants makes us Canada's largest population cohort, and has allowed us to be invited to other international activities, putting CanPath, if you like, on the world stage. One activity in particular that we're highlighting here is something called the International 100,000 Cohort Consortium, which is trying to take, say, not just Canadian data, but international data, and identify the common things that we've all been capturing across these population cohorts globally to be larger than the sum of our parts. And so this is an exciting activity. I'm part of the steering committee for this activity. And arguably, there are potentially millions of individuals who have done things like what CanPath participants have done in terms of providing information about health across the globe. So this is an exciting activity that we're proud to have CanPath be a participant in. Next slide, please. CanPath is a partnership among leading health institutes from coast to coast. So CanPath's National Coordinating Center is hosted at the School of Public Health, the Donald Honest School of Public Health at the University of Toronto, in partnership with my home institute where I'm sitting today, the Ontario Institute for Cancer Research. Our national funder is the Canadian Partnership Against Cancer. And you can see here, I won't have time today to read out all these important contributors and decision makers and regional funders, but they're all listed here, and we greatly appreciate their involvement in the program. Next slide, please. And I won't have time to read out everybody's names here, but the leadership team of CanPath includes Canadian health leaders across Canada, and you're going to be hearing from many of them today, in fact, so they'll be introducing themselves. As mentioned, John and I co-lead at the National Coordinating Center, the CanPath activity, and you can see here your regional leaders who are all part of the national leadership team across Canada. Next slide, please. And of course, we have our National Coordinating Center here at the University of Toronto. So of course, a big thanks to Megan Fleming, whom you heard from this morning, and Ted Kanya, our operations manager, for setting up this town hall today. Also, great appreciation to Kim Skeet, our National Scientific Coordinator, who developed much of the content for what you're seeing from today. I also want to highlight Asha Mohammed, our data manager, who supports our access to projects, which is a good segue to our next slide, please. And that is one of the things that we're doing with all of this data is trying to enable research, not just among Canadian researchers, but the international community as well. So all of this data is not just being used by research scientists who are part of CanPath, but they're being used by the broader research community in Canada. So a researcher will come in and they might ask us how they can use CanPath data. They'll reach out to Asha and the rest of the NCC team to get help with getting access to that data. And all researchers seeking to use CanPath data and biosamples must submit a request to the CanPath Access Office, following an ethics review, and then being reviewed by our Access Committee. So as we say here, ensuring your data is safe and supports high quality research is definitely our top priority. Next slide, please. And what we're also committed to, and this is something we've developed over the last couple of years, is training our next generation of researchers. So most of the science, most research done in most academic settings is actually done by our graduate students at our universities and our postdoctoral research scientists at our universities. So what we've developed at CanPath is a training set for the next generation of scientists who will want to get access to population health data. So this is something we're very excited about as well. It's called the CanPath Student Data Set, and it's critical for some of the work that we're doing in helping train instructors at Canadian universities. Next slide, please. As mentioned already, we're seeing exponential growth and access. So we're approving projects at an increasing rate. And this is great because we want your data, we want all of the investment in terms of participants and funding to be utilized by the research community to support both health research and basic biological research. And this is getting out there through peer-reviewed publications. So we're very excited about that growth. Next slide, please. And not only is this getting out there in publications, but it's also getting picked up by our media in Canada as well. So, and particularly the COVID-19 pandemic, we've seen that, and again, a great appreciation to those participants who've contributed blood samples and data to support our studies in studying a response to vaccines, who's getting vaccinated and who's not getting vaccinated, and who's getting infected and who's not getting infected. This has been critical in informing our decision makers at both at the provincial and national level about next steps and actions. And so you can see here that this is seeing significant media coverage as well, and it continues to as well. So we're pleased to see that CanPath can be used in this way as well. Next slide, please. And I think that's the end. And so I think I'll turn this over to, and maybe I'll introduce Donna. So Donna Turner is our scientific director of the Manitoba project. We're very happy to have her lead the Cancer Care, she's at Cancer Care Manitoba, and we're very happy that we're now engaging in Manitoba in terms of recruitment there. Sorry, John, I jumped in there with my introduction. So.
I welcome your words anytime, and over to Donna. Thank you.
All right, thank you both, Dr. Zawadala and McLaughlin. And welcome everybody who's participating here. It is my pleasure to be here speaking to you as part of this great project, Coast to Coast. And as the leader of the Manitoba Tomorrow project, we are a project which is the second youngest child. You'll see that the Healthy Future Saskatchewan cohort is just about to start the recruitment, but Manitoba is the cohort that's currently actively recruiting. So I see in the question and answer, and just to those of you from Manitoba, a special hello to you, and thank you very much for your participation so far. And we are right now in the process of signing people up. Because of COVID, we've not been able to see people in person and get blood specimens or body measurements, but stay tuned. We are optimistic that this summer we're going to be in a good place to be opening up our study center, and you'll be receiving an invitation to come and see us, and for all that exciting part as well. So I'm really glad to see such enthusiasm, people listening to what's happening in other parts of Canada and in Manitoba wanting to join that as well. Although I'm leading the Manitoba Tomorrow project, the focus of my talk today is really to be sharing with you the work that is being done by the CanPath network generally. And so I'll be talking on behalf of all of us and not just what's happening in Manitoba. Maybe if you can have the next slide. So the reason, though, that there's so much focus on cancer, for some cohorts of the CanPath network, they started out as a cancer cohort that is a cancer prevention and scientific platform. But we know that many of the things that affect cancer also affect other chronic diseases. So we also are very interested in expanding that footprint more broadly. But just to focus on cancer. So I'm a cancer epidemiologist by training, and this is looking at things through a lens, my lens, as in that seat. You can see that cancer poses a huge health burden on the health of Canadians and the healthcare system. And this slide here gives you some fast facts, including that almost 230,000 Canadians will be diagnosed with cancer this year. We know that cancer is the #1 leading cause of death in Canada. And we know that 2 in 5 Canadians will develop cancer in their lifetime. Now, just one of the things to note, I also noticed in the Q&A that someone was asking, does this include those sort of minor skin cancers? It does not include non-melanoma skin cancers. So that 2 in 5 number is the other major cancers that we see, of which the most common are lung, colorectal, breast, and prostate cancers, but we see many, many other kinds of cancers as well. There are actually over 200 different types of cancers that we would be able to study with a platform like CanPath offers us. You can see that we have a lot of statistics in our back pocket that we know motivates us to really talk about the importance of finding out more about cancer. The participants in CanPath provide information about lifestyle, environment, and medical history, and this helps researchers understand the factors that can increase the risk of cancer. One of the fast facts that's not on this slide, but that you might like to know, is that based on what we know today, about 40% of cancers could be prevented. But we think that there could be maybe more. If we found out more, we would be actually able to raise that 40% number to understand that how we might be able to prevent even more kinds of cancer. So that's one of the things that we're really hoping to do here in CanPath. One of the great things about the CanPath design, the cohort design, is it's a longitudinal study. You will all know that you've signed up for potentially 50 years of follow-up. And this enables us to focus not just on what might cure cancer, but also how to prevent cancer entirely, or how to find it early when treatments are even more likely to be effective. All right, next slide, please. So here you see that some basic statistics from the CanPath cohort to date. As was said, there's over 330,000 Canadians that are part of this cohort. And at the time that people were recruited, you can see that almost 13% of the cohort had already had a diagnosis of cancer at some point. But that means 87% did not have cancer. And so we're certainly interested in following up people who didn't have cancer to understand what might lead them to have cancer in the future. And in fact, the kind of questions that we have asked at that initial or baseline questionnaire include over 350 variables related to cancer outcomes. This includes how we live, so what we eat, how much we sleep, how much we exercise, where we live and where we work, as well as things like body size and your health history. All of those things relate to cancer outcomes, both the likelihood of developing cancer and the likelihood of being treated effectively and surviving it. All right, next slide, please. So just to reiterate the point about being coast to coast, here is an example of cancer research that are happening on each coasts. On the West Coast, led by Dr. Rachel Murphy at UBC, you can see there was a study that has been underway to using CanPath data to look at lifestyle and behavior changes to prevent lung cancer in never smokers. And this is something that we in the cancer world are very concerned about right now, although tobacco smoking is still very much a player in lung cancer risk. We are seeing increasingly lung cancer developing in people who didn't smoke. And so what's leading to that? And this is one of the things that we'll be able to learn in this in CanPath with this platform. On the other coast, the East Coast, looking at arsenic in drinking water, and being a major public health issue, it's actually a health issue for cancer as well, as some colorectal cancers are increased risk for people who have been exposed to arsenic. So we are really using the whole country in order to be able to answer some of these questions. All right, next slide, please. So Dr. Awadallah was talking a bit about this, but if we just focus in on the publications focused on cancer, there have been almost 80 of them published to date. And you can see that things started off slowly around 2005 and really picked up steam in the last decade. And that really reflects the fact that, first of all, more cohorts were developed in each one of the regions. Secondly, more participants enrolled. And so as we had more people, we were able to ask more questions and have what they call statistical power to be able to answer those questions. The third thing over time is that we had data maturing. So people who provided us data a long time ago, and Alberta's Tomorrow Project being the earliest one of all the cohorts, started recruiting in the early 2000s. And so we were actually had enough follow-up to be able to really study people over time. And so that was the third thing. And the last thing is that we have really been promoting the availability of the CanPath platform to many scientists. And so that's also contributed to the publication record. All right, and to the next slide, please. So just to give you a flavor of the sorts of publications that we have. So just the top 6. So looking here, things like having low body mass index and high waist circumference, at lower parity, that is lower number of children, and family history of breast cancer were associated, all of those things, with increased risk of breast cancer diagnosed before 50, which is considered early. And that work was done using data from cohorts in Alberta, Ontario, and BC. You can see here more work by Dr. Murphy at UBC talking about low fruit and vegetable intake and whether you had too short sleep or too long sleep, or relatively speaking to an average, being associated with increased lung cancer among non-smokers. And then looking at the genetics, which Dr. Awadallah mentioned. So being able to study for those cohorts where we have blood specimens to look at genetics and finding that we were able to actually mine this and find out some new clusters of genes that were being predictive of breast cancer onset. For colorectal cancer in particular, we've been looking at fiber intake and cancer development. And so this work by Dr. Grundy and company in the Alberta's Tomorrow project really showed that that about 6% of all colorectal cancers were associated with insufficient fiber uptake. So again, questions that were answered by our CanPath participants, enabling us to answer questions today. Looking at lifestyle related prevention recommendations and seeing how well people adhere to them. And the study by Whelan and company has found that actually Canadians are not necessarily very good at adhering to the sorts of recommendations which we may be somewhat tired of hearing, but things like having a healthy weight, not using tobacco, and eating fruits and vegetables and maintaining physical activity. All of these things are out there, but it's really interesting to know how people are doing it with adhering to them. So maybe we need a better way of messaging is part of the findings of that study. And then finally, some more work by Cardigan in Quebec, looking at genetic sequencing for people without the high-risk breast cancer genes of BRCA1 and BRCA2. And looking at other genes that are at risk for hereditary breast cancer. So just a taste of the sorts of things that we have. And as we say, almost 80 articles just on cancer alone. So we'll go maybe to the next slide, and it's a very similar one to one that you saw Dr. Awadallah presenting, and just to provide a very, very short snapshot on the sort of work that can be done here. This project was being championed in Ontario, but you can see that using the CanPath cohort, we have been able to link information to find out if we could actually find out if people are at increased risk for disease despite the fact before. So we have people that are not diagnosed with cancer, and we can sort of follow them forward to see, and then if they develop cancer, find out if we could have actually found that earlier with new techniques. So what you see in this slide is that we have the star where participants joined, then a blood sample collection, then a development of cancer, and being actually able to analyze this information on people who had cancer versus those that don't, and are there actually molecular markers in the blood that would have given us a hint earlier on. So the next slide really summarizes some really exciting new findings from this study. And so you can see here, Dr. Awadallah and his PhD student, Nick Cheng. And we're looking at patterns of DNA in the blood. So one of the things that happens is that cells routinely, even healthy cells, go through a cell process where they die. But cancer cells, when they die, they actually leave a fingerprint that looks different than normal cells that are dying. And this research team used that with information that was collected from CanPath. And so looking at people who ultimately developed breast cancer. And in this study, although mammography right now is our best bet for screening for people aged 50 to 74, in this study, they looked at people who developed breast cancer within 7 years of enrollment, and did an analysis to see if they had these different fingerprints of looking at abnormal cell death back earlier when they were enrolled, and compared that to the same kinds of fingerprints we would see in people who didn't develop breast cancer. And what these researchers found was that we actually had some signals very early on that people who were going to develop breast cancer might be going to develop it by looking at this abnormal cell death. Now, this is a very early study. Science is never based on just one study, and so we'll be doing lots of work to follow this up and repeat this study and explore what this means. And it certainly, we are going to be doing mammograms for a long time because because we have to actually get all of the evidence in place. But this really is exciting because it speaks about the future and where we might actually be able to go with health services delivery in the future in order for and using work based on the CanPath cohort. So one day, instead of a mammogram, we might actually be doing a blood test to see if you are at increased risk for breast cancer. So that's the sort of thing that's new, and we will be proceeding. So on to the next slide. And that was my last one. And John, over to you to introduce Dr. Dummer.
Thank you, Donna. Also to all of the participants, some of you would find that our website is down. We've never been in a position like this where we have 5,000 people on a webinar, and many of you with your interest have gone. For example, I couldn't even get onto our own website to try to share a couple of links in the chat. So I'll come back to discuss that, but please bear with us. I think the implication is partly that the dialogue that we're starting today will continue over time, and we look forward to that if we can't provide all of the evidence or answers to your specific questions today. Now I'll introduce Dr. Trevor Dummer. He's CanPath, as he joined CanPath as a research director and one of the leads for the Atlantic Path program in 2008. Then he served as co-scientific director for the BC Generations project from 2015 to 2021, and he's now the National Scientific Co-Director. As well, he is the Canadian Cancer Society chair in primary prevention, and he's an associate professor at UBC. So Trevor, over to you.
Thank you for the introduction, John. So we can go straight to my next slide, I think. So what I want to talk about here, and this is sort of building really on what Donna and Philip have just mentioned and talked about, how we're using some of the information that you have provided to actually understand, in particular, my interests are in cancer prevention. So understanding how we can prevent chronic diseases and cancer in relation to things like occupational and environmental exposures. Now, my background, my training is actually in health geography. So I'm really interested in features of the built environment and where we live, work and play, and how that really impacts on our cancer risk and our disease risk, and how we can understand more about the built environment. I'm coming to you today from a very sunny but unusually snowy Vancouver, and we're trying to look at what are the features of the environment around us, how that actually impacts on cancer and chronic disease. So I don't see my next slide. I'm going to keep talking. I'm hoping that others can see my slide. It's not advancing yet. Ah, there we go. Thank you. Maybe there's a delay. Sorry about that. So I want to talk about exposure assessment. So there's a number of ways that the information that you're providing us and the information we're able to gain from that information, how we can actually assess your exposure to many different things related principally to your occupation, where you work, but also where you live, so your home address, and in some cases residential history. So obviously many of you have filled in all these questionnaires at baseline. There were lots of different questions about behaviors. Some of that information was also related to exposure. So you may remember reporting sun exposure in the baseline questionnaire. You may remember reporting secondhand smoke exposure. We know passive smoking can be a major hazard for things like lung cancer. You also would have reported occupation. And as we've gone over time, we've gone back to you with some follow-up questionnaires. Many of the regions have completed occupational history questionnaires. We've also got the COVID survey, which many of you have completed. And from that, we can get information about exposures related to our occupation. For example, do you work in shifts? And there's many scientists have decided to look at whether or not shift work and different shift patterns from a regular 9-to-5 type day to night shift, for example, how that impacts on cancer risk. So we've got that information which we can use, but becomes much more useful and usable when we either link it to other databases to enhance that information, or we maybe use computer systems and sophisticated computer processing to actually recode or make sense of some of that information. So if you think you filled in an occupational history questionnaire, you probably filled it in, well, you will have filled it in as a free text box telling us what you did. So you may have been very specific, very accurate, and put your job title down, or you may have described it in a bit more detail. To actually make use of that to identify, you know, what occupations people are involved in, how that might be associated with certain chronic diseases. We use an expert system to actually recode that information into a job classification, which we can then link to another database, which can tell you about the exposures that you may actually be routinely exposed to in that occupation. So that's making sense of that simple data you provided us to be able to estimate some exposure information. Philip touched upon the CANU study, Canadian Urban Environmental Health Initiative, which has basically been building environmental data sets across Canada. And what we can do, and this really is some of the really interests me as a health geographer, we can use some of the information you provided us. You provided us with your address, so we got a postal code. We can actually link, because CANU for every postal code in Canada, they provided a whole range of data sets, environmental exposures. I'll talk about those on the next slide in a moment. But basically, we've used your postal code to actually connect you to things like urban green space or rural green space. Here's an example here. Fine particulate matter, which is air pollution. And we know that particulate matter, that when we breathe it in, gets into our lungs, can go very deep because they're very small particles, get lodged in your lungs, and can cause can cause lung cancer, but can cause other chronic diseases as well. So we're able to use the CANU data. But as you saw on the previous slide, your privacy, maintaining your privacy is central to what we do. You know, you signed up for this study, you signed up for the data to be released to scientists through an access process that's approved research to be conducted, but we assured you that we would protect your privacy, maintain your privacy of your data. And we do that by not releasing, obviously, your name, but we don't release your address, we don't provide your postal code. So what happens is, once the linkage has been done of your postal code to these environmental data sets that you're seeing here on this slide, once that's done in-house by our team, the postal code is removed from the data that is provided to the investigator. So the investigator gets information about you and about maybe your chronic diseases, where you work, your occupation, and also, for example, what sort of nighttime light was in your neighborhood. So are you exposed to light at night? We know that can impact on sleep, and we touched earlier about how sleep might actually impact a whole range of different chronic diseases, and has been potentially may impact on cancer. So maintaining privacy in this is really important. We do that by removing the identifiable information before it's provided to the investigators. Okay, so that's two ways where we can get occupational environmental exposure. So we go to the next slide, please. One of the other ways as well is because, as Philip mentioned, we've been collecting samples from you, biological samples, predominantly blood samples. And so when we collect a blood sample, we can store that in the biobank, and then we can use that blood sample. And Guillaume will be talking in a moment about genomics and how we can use things like DNA and other stuff to actually look at genetic associations with chronic diseases. But we can also use your blood to estimate or measure things like lead or other environmental exposures. So we can use your biosamples to get a really good estimate of your exposure levels. One of the other things, and this was actually limited to the Atlantic Path cohort, and this is something that very close to my heart. I started with CanPath when it was CPTP right at the very beginning, working with the Atlantic Partnership for Tomorrow's Health, and we were interested in environmental exposures, so we decided to collect toenail clippings. And these are really important for two things. One, when you clip your toenails, they're about 8 to 12 months old. Toenails also get deposited with things like environmental heavy metals and other things you're exposed to. So they're actually a window onto your past exposures, and a very good window. And there've been lots of studies establishing that these are really good, what we would call a biomarker of a particular environmental contaminant. So the toenails are a really good way of measuring, and they're a non-invasive way of measuring, because it's a simple thing for you to clip them. Actually measuring the quantity of things like lead or arsenic or other heavy metals in the toenails is actually pretty yucky, because some poor research technician has to go through a whole range of processes in the lab. So it's not that simple, but actually it's a really, really nice way of actually gathering that information. The other reason I think this the toenail collection is so important is it actually gave the Atlantic Path a Guinness World Record for the largest toenail collection, which is for someone brought up in the UK and at the age of sort of 10 or 12 would routinely get the Guinness World Record book at Christmas. This is something that was like one of the sort of very proud achievement for me and the rest of the Atlantic Path team. But as you can see from this slide, we've used that information already to really do some really exciting research, understanding in particular the impact of arsenic, which is actually a problem across Atlantic Canada and particularly in Nova Scotia. The impact of arsenic in drinking water. We're looking at a cancer risk. We're also trying to understand why some people are more likely to accumulate arsenic in their toenails than other people. And we've established some of the relationship between things like body fat and actually how well you might actually excrete the arsenic rather than actually absorb it into your toenails. So some of what we now are understanding about how arsenic acts in our body and what level of cancer risk, for example, may be associated with that arsenic level is really being explained by some of the Atlantic Path data. Okay, can we go to my next slide, please? And so really your information is being put into action already, and Philip mentioned, and Donna's focused on some of the cancer studies. There's been also, for a young cohort and 10 years of follow-up or whatever it is, it's not actually that long for a longitudinal cohort. We're considered a very young cohort. We're already really starting to uncover some exciting things about, as this slide suggests, how the built environment, how the natural environment may actually impact on your health. So you'll see there's a slide here from Metro Vancouver, and this is a study we conducted where we're looking at walkability of communities and how it impacts on physical activity and obesity. So walkability is simply, do you live in a neighborhood where you don't necessarily need to own a car? You can actually move, walk to work, walk to shops and stuff like that. So some of you may be familiar with the walk score. Now, this slide shows that in the most walkable communities in Vancouver, there's a 176% increase in walking, which is great because we know that just simple walking is really good for our long-term health. That translates into lots of moderate to vigorous physical activity and an increase in that. But most importantly, it reduces obesity by nearly 40%. And we know that obesity is a major risk factor for cancer and other chronic diseases. So just by creating more walkable communities, the obesity generations data in this instance is actually there to show there's been a huge reduction in obesity just because of that. Okay, I think that's all I wanted to say, really. Just talking about some of our information in action. I'm now going to hand you back to John, I think, who's going to introduce Guillaume.
Thank you, Trevor. We'll move quite promptly on to the next presentation by Dr. Guillaume Lettre from University de Montreal and Montreal Heart Institute, and who's an associate, one of the co-directors of Cartesian in Quebec. So over to you, Guillaume.
Merci, John. Alors, bonjour à tous.
Thank you, John. Hello, everyone.
Next slide.
Today, they've given me the task of presenting CanPath with Genomics, and that started in showing, I want to start with an image to demonstrate my view of human diseases. There are people who are located at a good distance from the precipice, and the risk that we all have to develop. We also have people that are higher risk for genetic reasons. They're located closer to the precipice, and so there are people who will fall and who will be off the precipice and who will develop the illness. What you can imagine from this image, and we all have a different level of risk with chronic diseases. So this will be determined by environmental factors as well as genetic factors. So these risks are not only fixed, but they also, they change over time. For example, in getting older. Next slide, inaudible. Next slide. So the difference between individuals, the fact that we don't have the same genetic risk, it comes from the fact that, of course, there are differences in our DNA, and when we watch that, we're responsible for features that are proper to our family. For example, the color or color blindness, being left-handed or right-handed. On right, for example, I can't see anything. You can see a number 8. These are factors that are controlled, that are under the influence, are controlled by genetics and DNA. There are also characteristics, for example, influenced by DNA, like the color of your hair or skin. It's also influences the risk of developing certain illnesses like cancer and diabetes. The difference in DNA between individuals allow us to understand better the differences, that there are genes that are responsible for different chronic illnesses. Next slide. And so to be able to understand the co-genetics, we have to be able to measure them to differentiate between what differentiates someone who develops a cancer from someone who doesn't. So we've developed in the last decades science. We talked about a DNA that comports the genetic code. And that's the differences between you and I, which dictates the risks we have of developing certain illnesses in combination with environmental factors. These differences in the DNA, like it has with other molecules like RNA and proteins. Next slide. So with this lens, we developed a genomic science, and that's my focus point of the presentation, the variation in DNA. With CanPath, these are all important over the last years. We created an immense database, genetic database, and protein and RNA, and in order to better understand and explore the causes of certain some of these diseases. What we're going to do in the next two slides will be the utility of genomics to explore the genetic causes of chronic diseases. Next slide. And so I wanted to absolutely show you this image, which is a really superb image. What we see here is a two-dimension of the Quebecois cohort in Cartagena. And the analysis that Luc and those have done here is to regard the genetic similarities between participants in Cartagena. And we projected this similarity in this graph. Each one of the points here, colors are not important, represent one individual in Cartagena. And what you can observe is that there's a major central group that represents the majority population of Quebec. That there are other groups on the next slide. And when we look at these other groups, what we realize is that we have people with different origins, for example, as Asian, Latino, Arab, African, for example. And so the history of Quebec, that would be also interesting to see the founding, where people are originate from are found on the graph. We use genetics to identify origin, but also the importance that a CanPath gives to these minority groups. We want to be ensure that genomics applies not only to the European majority population, but also to all the other populations in our Canadian population. So there's a question in the Q&A about the First Nations people. Yes, there is an underrepresentation, in fact, of these individuals in CanPath. It's something that we are involved, engaged, and which we wish to change in the years to come. Next slide. In fact, the information I'm going to show you are the laboratory research. I'm interested in the risk of developing cardiovascular diseases as well as heart attack. What you'll see on the left is that the cardiovascular illnesses, smoking, obesity, diabetes, blood pressure, all these factors we understand that to have an effect on myocardiopathy. There's a category that is
So what we can see here are certain factors like conventional risk factors and other factors. So if we look at the last point that's on the right, that's showing the conventional risk factors, we can ask, can this work amongst the Quebecois population in the Cartesian study? And the answer is yes, because what you see here is the distribution of genetic scores within individual that are in Cartesian, and in green, those are those who did not have a heart attack and the other ones who did. And you can see that there's a separation. It's not perfect. One is superimposed upon the other. However, the individuals who suffer with a heart attack, they have a polygenic or a genetic score that is higher in turn. So that shows us that genetics do play a role in this. And what is very encouraging from the future is to see how this combines with other CanPath cohorts or on a worldwide level in order to develop biomarkers, predictors based on other molecules that can be at play. Final or next slide, please. So to conclude, genomics, it's a tool that can define the cause of human illnesses, understand the biological mechanisms involved, and explore new strategies. And this is really important in terms of what we're doing at CanPath. It's really essential to carrying out or realizing the genomics potential.
Thank you ever so much, Guillaume. And now, we'll quickly introduce Dr. Robin Urquhart, who came in 2021 to serve as the scientific director for Atlantic Partnership for Tomorrow's Health, which is Atlantic Path. She's an associate professor and Canadian Cancer Society chair in population cancer research at Dalhousie University. So Robin, over to you.
Hey, thank you, John. So thanks everyone for being here today. And I have the pleasure of presenting some of the findings from the COVID-19 work that we've been doing over the past 2 years. Next slide, please. So let's begin with some highlights. So CanPath, and I would say sort of the infrastructure and the partnerships that we've built over the last decade and longer, really enabled Canada to respond very, very proactively to the COVID-19 pandemic. So in fact, we were in the field, as it were, so in the field collecting data within 4 weeks of COVID-19 being declared a pandemic. And certainly we were the first national study, so the first study in Canada to really confirm evidence from clinical trials of sort of the vaccine, so the efficacy or the effectiveness of the vaccine using real world data from Canadians, so from many of you. And certainly we're one of the largest antibody studies in the world around COVID-19. Next slide, please. Thanks. So as many of you know, we carried out a national COVID-19 antibody study, which was funded by the Canadian Institutes of Health Research, the Public Health Agency of Canada, and the COVID-19 Immunity Task Force. And basically the study involved collecting COVID-19 related data and outcomes from more than 100,000 Canadians. And we started this again very early on in the pandemic. The study also involves longitudinal profiling of COVID-19 antibodies. So those are in people who have been diagnosed with COVID-19, but also in symptomatic, asymptomatic, and susceptible Canadians. And finally, it's involved supporting pre and post-vaccine immune profiling. Next slide. So more than 100,000 Canadians completed our COVID-19 questionnaire. And in this questionnaire, we asked information around test results, so COVID-19 test results, suspected infection, information around symptoms that people have experienced, whether people were hospitalized or received medical care due to COVID-19, their current health status, risk factors for COVID-19, certainly sources of exposure and the impact that the pandemic has had on people's job status, but also sort of on their mental well-being, their emotional, social, and financial well-being. Next slide. And we also, as many of you probably know, invited about 20,000 participants to provide a blood sample, and that was to support antibody profiling. And I'll show some of the findings in a minute. We also targeted sort of some high-risk populations or settings, so residents of long-term care homes, areas in the country with a high prevalence of COVID-19, and people who are living in underserved communities. And as many of you will know, we mailed out dried blood spot cards to participants to collect these blood samples. Next slide. So who participated in this work? We can see here that the average age of participants was 62.7 years, but we had a real range between people who, so someone who is 22 years old right up to 93 years old. We see that most participants, about 2/3, were women. And this was in the early days of these data here, in the early days of the vaccine rollout. But we do see high variability in the type of the vaccine that was received. As well as sort of vaccination status varying across our antibody study, across participants in our antibody study. Again, early days. Right here on our left-hand side, because I'll talk about some of the findings later, but many of our participants in the COVID-19 study did report a current or past cancer diagnosis. So you can see that a number, the gray and the orange bar here on the bottom left, you can see a number of people were currently in cancer treatment or had been diagnosed since the pandemic. And that, about 23% or so have been diagnosed at some point with cancer. Next slide. So we can see here public health precautions that were taken by participants after the pandemic was declared. A really high proportion of participants, adhered to public health guidelines in terms of social distancing, went out in public, washing hands more regularly, avoiding crowds and large gatherings, avoiding leaving the house for non-essential reasons, and so on. We also found that some of the precautions people took varied by group. So for example, women reported being more likely to wear masks, more likely to stay at home, more likely to stock up on essentials, and to avoid visiting people outside of the home. Next slide. So 1 in 2 participants reported COVID-19 symptoms in the first wave of the pandemic. So these data are from the first wave, but we see just a small proportion here tested positive for COVID-19. So these are the on top, or were hospitalized from COVID-19. About 12% were tested for COVID-19 during the first wave. Next slide. Okay, so we used the blood samples that we gained to really look at the levels of immunity to COVID-19 in our population. And so levels of immunity that, so basically one's immune response after COVID vaccination or after actually infection, so getting COVID-19. And what we see, the top 2 sort of bars, I guess, what you can really see here is that the highest antibody levels that we see in folks are observed in individuals who are fully vaccinated with an mRNA vaccine. We also saw that the highest levels, so you can look at the bottom 2 bars here, were in those who were both doubly vaccinated, but also had been, you can see the doubly vaccinated or one vaccine, but also had a prior infection of COVID-19. Next slide. So COVID-19, we did find had a large impact on participants' ability to access cancer care. So in our COVID questionnaire, we did ask people about their access to healthcare during the pandemic. And we did see disruptions in access. So if you look here, and in healthcare in general, so if you look here at the first set of bars, use of virtual appointments, we certainly saw that sort of go up with everyone across the board. But the green line here in all of these indicate participants, so people who had responded to our work, to our COVID work, who are currently undergoing cancer treatment. So you can see here that a relatively, substantial proportion of participants had their treatment canceled or deferred, their surgery, other medical procedures, either canceled or deferred because of the pandemic. And we can also see that a substantial percentage of people also delayed seeing a healthcare professional about an existing problem or concern because of the pandemic. Next slide. I think this is pretty much my final one. So when we looked at the effectiveness or the efficacy of the vaccine in individuals who had a history of cancer, what we found was that for those people, so the very darkest blue on the left side are people who did not have cancer. So what we found was that participants who have cancer or have a history of cancer have just slightly lower antibody levels to COVID-19 after 2 doses of vaccine compared to those who had no history of cancer at all. So you can see this here in the slide and in the bars. But they still have a high level of protection. So that's a good thing. Next slide. So this is my final slide. All I really wanted to say here was really, our COVID-19 research has really provided evidence that I would say is been relevant to all Canadians during this pandemic. And really, I wanted to emphasize that a lot of the work that we've been doing and you've been doing, that all of the data that you've been providing us and information really has provided national guidance around planning, pandemic planning and decisions that have been made here in Canada during this pandemic. So I'll stop there. Thank you.
Thank you, Robin. And last, but certainly not least, we'll turn it over to Dr. Jennifer Vina from Alberta's Tomorrow Project, who will speak to us about some of the work she leads in Alberta, but across Canada as well. Jennifer.
Perfect, thanks, John. So I'm gonna go right into my next slide. I don't think I have to convince you that diet and physical activity are really important for cancer and chronic disease prevention, because I've seen a lot of you ask specifically about it in the chat, which is wonderful. So just to say that there are a lot of components around diet and physical activity independently and collectively that we know are important to health. Next slide. But the point I wanted to make here with this one is that it's not just about preventing a disease. If you think about it, we're always trying to prevent something, whether that's preventing a disease in the first place, preventing progression of that disease, or say promoting return to health, or preventing unnecessary pain and suffering. So why I'm so passionate about diet and physical activity in particular is there's no point along these trajectories where what you eat and what you do is not going to play a role of some kind. Next slide. So CanPath overall has collected fruit and vegetable intake and some indicators of physical activity when you joined, when the study started. And it's really important to have this data, but they're actually, we only collected select markers at that time. However, some of the cohorts, Alberta's Tomorrow Project, Cartesian, and Atlantic Path in particular, have collected especially more detailed dietary data as well as physical activity at different times. So I'm just going to go through a couple examples to show you how we use this across the cohorts in CanPath, as well as some of these individual studies. Next slide, please. So this is a study that Donna mentioned with Dr. Darren Brenner by Joy Pater is the first author, looking at reasons or causes of early onset breast cancer. So this is breast cancer in women under 50. And so like she mentioned, greater body size was associated with lower risk, but greater waist size was associated with increased risk. And that can be a little bit confusing. But the study, unfortunately, wasn't able to show whether there was a role for fruit and vegetable consumption and physical activity. This might just be because there wasn't enough differences between people, or because only those sort of limited indicators were looked at. Next slide. So I'm going to show you one, excuse me, that goes into a little bit more detail. This is from Katerina Maximova, and she used data from Alberta's Tomorrow Project, where when participants joined in 2000 to 2008 or earlier joiners, we sent them a questionnaire asking about a wide variety of foods that they'd eaten over the last year. And so she used this data to really look at the role for red and processed meat, which gets a bad rap when it comes to cancer risk because it is highlighted as a risk for cancer. But we know that red and processed meat, you don't eat foods in isolation. You typically would not sit down to just a steak, or hopefully you're not. So we don't eat foods in isolation, we eat them in combinations. So you really have to look at what you're eating and in the totality of the diet in order to assess what is the risk. So she looked at people who ate high amounts of red or processed meat, like deli meat, for example, hot dogs, etc., but also high or low amounts of fruits and vegetables, whole grains, and fiber. And what she found was that it's the combination of high processed meat and low fruits and vegetable that was actually one of the worst patterns, compared to high fruit and vegetable and low processed meat. And then if you have sort of high intakes of both, it's somewhere in the middle. So it's not necessarily that it's just that red meat is bad for you. It really depends on what else you're eating in the diet, and having that holistic view of the diet in order to estimate risk. Next slide, please. And then this is just another study that I wanted to highlight related to physical activity. So this is Dr. Vicky Ho, who is looking at work-related physical activity and risk of lung cancer. So physical activity also well recognized for reducing risk for cancers, but there's different types of physical activity. So the type of physical activity that you engage in and enjoy in your leisure time or your recreational time may be different than the activity that you engage in at work, and also the different types of exposures that you might have in jobs that are more physically demanding may be different than what you would see if you were just going for a jog in the park, for example. So understanding these differences is really important to take into context. So what she's doing is looking at how the physical activity performed at work may relate to lung cancer compared to different types of physical activity. So that study is still in progress. Next slide, please. So I just gave you a little bit of a flavor. That's definitely not the extent of studies that have looked at diet and physical activity in CanPath. So I just thought it might be important to highlight, what's still to understand about diet and physical activity. We know it's important, but we really don't still know all the factors involved in how your diet and physical activity needs and how your behaviors change over time, because that will impact your risk for protection or development of disease. And like I mentioned, it's really the impact of both the parts and the sum of the parts. So diet and physical activity components themselves, but how they also interact with your genetic background, your environment, other lifestyle factors. And finally, I think the context in which people make their diet and physical activity choices. And sometimes we use quotations because your environment, your economic and your social factors or cultural factors can really influence your diet and physical activity choices and behaviors. And there are different things that are out of people's direct personal control. I think about it like trying to make a healthy choice at an airport. You're going to be limited by time, money, and availability, and it may not be the choice that you make under different circumstances. Next slide. So how do we understand more about diet and physical activity? Basically, we need to collect more and better data because what goes in determines what you can get out of it. And I just want to say, this is something that we are talking about at CanPath. I see many of you asking why we're not asking more about this. So we are talking about it. The problem is that to do it well, is a little bit more complicated than other factors, right? It's not smoking or not smoking. When we ask about diet, you think about how many food-related decisions you make in a given day. It's a lot, actually. So it's a very complicated behavior to collect. So we're trying to figure out how we can do this well while respecting your time and effort so that we can balance those two. And I think that's my last slide. So I know that was quick, but thanks, John.
Thank you very, very much, Jennifer. I will just wrap up with a few final comments. Next slide, please. In particular on this slide, I just wanted to summarize where you've heard where we are now in the types of work being done, just some comments about where we plan to be over the next 5 years. So we continue to grow the data resources and have these data be used even more by researchers across Canada and internationally. Many of the questions that have come up include topics related to how is the knowledge used? And so there are many examples that we could go into, but basically that ongoing knowledge transfer to improve health to improve healthcare, to improve health systems, to improve our communities. These are all part of the knowledge transfer activity that we will continue to support. The continued enhancement of the data and the biospecimens themselves they will continue to evolve, such as the specimens that have been kept in the biobanks in each province, that they can be turned into research-ready data. Sustained growth in strengthening CanPath as what we are now, with your help, as Canada's premier health research platform. There's nothing else like CanPath in Canada. It's never been tried before. There have been other large studies, but they've never had all of the features of healthy people across the life course being volunteering to provide as much as you have, and then participating over time to advance knowledge across so many different dimensions. So that profile as Canada's premier health research platform will continue to grow. It's important for us also to continue to be recognized as a data platform where we apply the top tier standards around data security, ethics, integrity, driving scientific merit, and uniquely being able to do things locally within each of your provinces while wrapping things up at the national level into a federated data system. I see that one of the questions that came up just a moment ago was about such things as data security. And it is true that over the course of the time that we've been working on with you, our data security, backup systems, password protection, encryption, all of that is top tier. We've never had a breach. There are many layers of protection that secure that. For example, at our national data systems, we do not know your names and addresses. That's the type of information that's kept at the provincial level. So they're being recognized as a premier platform in all ways is important. And then aiming to deliver improved disease prevention, treatment, and performance of the healthcare system across the population. I will add, as a result of today, one more priority, I would say, for the next year or two, and that is, with your interest, I think we need to do this more. It's obviously, we've tried to pack a lot in a 1 hour, 1.5 hours. It seems that there's enough interest and tremendous input from you as participants that we could actually repeat this with maybe a bit more of a focus on different themes so that we can answer your questions and then we can have dialogue with you more directly. Next slide. One of the final statements is that you've heard from Donna Turner from Manitoba, but also who's leading the Manitoba program, and Saskatchewan. Riaz was not able to be here today, but we have 2 provinces where there is still ongoing recruitment, and questions have come up too about, well, what about the territories? Well, the territories are of interest to us. We've offered to share our expertise, tools, systems, and supports should there be interest and ability to expand to cover all of Canada. Next slide. There are many sponsors and hosts. This is showing the logos of the many groups. Each regional cohort is hosted at an organization that provides a lot of supports to us. There are several funding agencies as well. So this really is quite an important multi-institutional collaboration. Next slide, please. And most importantly, thank you again to the participants across all regional cohorts who have generously donated your time, information, biological specimens. CanPath is where it is now because of your contributions. We're grateful. I think Canada is grateful, and your ongoing commitment is tremendously appreciated. I think there we can turn off the slides and come back to have some more of the Q&A with the actual speakers. Now, there are so many questions that have come up today. I think what we can do is prepare a summary of the questions, and we will prepare a kind of a frequently asked questions kind of summary and provide some themes to cover all of your questions, which can be posted at the CanPath website. And then we will also ensure that there's a link through to the regional cohorts. And just again, with regard to privacy, for you as participants to know, we at the National Coordinating Center in Toronto do not have your ID. We don't know how to contact you. So that's one reason why we can't just send it out to you. And that's done particularly to ensure privacy. Now, there are some questions that I could ask some of our panelists to refer to. Maybe I'll start with Philip. One of the questions was, it is said that the data are being used internationally. Can you elaborate on that?
Oh, okay. So very specifically, our data, we have very rigorous access requests and very rigorous access protocols for its use. And while we are open to international research, we have to say that primarily most of the access requests are coming from Canadian scientists. What I described in our slides today was largely around how we're sharing the data variables, not the data itself. So the kinds of data that we're capturing, not necessarily the individual data points or the individual data provided. So we're effectively just trying to share with other research programs across the world. These are the kinds of questions that we're asking of our participants, right? This is the kind of data we're capturing. We're not actually sharing, at this point, the actual data itself with other international scientists. Sorry.
Okay.
Yeah.
Thank you. I'll turn over to Donna. One of the questions was how can I help new participation in the study? So Manitoba's a prime example of that.
Right, so that was a great question. And so basically in Manitoba, we are actively recruiting. Other cohorts are not actively recruiting for the main part of the study. But if you're in Manitoba and you're interested, we are taking all comers. So you can go to our website. You can actually just Google the Manitoba Tomorrow Project if you like, or you can go to www.cancercare.mb.ca/MTP. And that'll take you right to the Manitoba Tomorrow Project. You can call us, you can email us. We'd love to hear from you. And for folks who might know someone in Saskatchewan, tell them that starting this spring, they can contact the Healthy Future Saskatchewan website as well, and they would be very happy to have those people register. So we've been really putting the word out. I noticed in the question and answer, there was some suggestion about family physicians being involved. It's a great idea. We've also been working with some communities. So we've been trying to, in terms of getting maybe less represented groups joining us. We have been working with communities to get out and talk about the study and what it's about. So basically, contact our website, contact us by phone. We'd be very happy to hear from you.
And if I can add that in other provinces, when funding and capacity permits, there could be other opportunities to expand participation. And the same is true with the territories as well, which I've commented in the chat about. Maybe one question that's come up about migration and moving. Robin, the question was, I recently moved to a different province. Does this mean I have to join a different cohort?
So no, so that's a simple question to get back to. No, it doesn't. So if I'm in Nova Scotia here with Atlantic Path, and so you would stay in your home cohort per se. So for us, if we have a participant from PEI or New Brunswick that moves to Ontario, they would remain an Atlantic Path participant, and we would get the new mail-in address and send up follow-up surveys eventually.
Thank you. Trevor, one of the questions was, I have been a participant for years. Has my participation helped? Perhaps partly a knowledge translation.
And I think that the short answer is yes. And if you look at, just some of the presentations today, 220 scientific papers already, and the numbers are increasing hugely. And, as I've mentioned, this is a really young cohort. The thing about cohorts is they get better over time. what we know about heart disease comes from the Framingham Heart cohort that started years and years ago, and the UK Civil Service cohort, which was again started decades and decades ago. Much of what we know about breast cancer comes from the Nurses' Health Study in the US, which is years old as well. So yes, we're really already starting to understand lots of different things about cancer, environmental exposures, how it impacts on our health, and I think, you know, I hope that what we've presented to everyone today, really does explain that. Huge number of funded projects already gone through our access process. I personally have supervised, you know, a couple of PhD students who have completed their PhDs using CanPath data, number of master students as well, and many other students now joining me. So, you know, we're training the next generation as well as providing scientists with really useful data. So I think, you know, your participation, the data you provided some 10, 12 years ago, set the baseline, hopefully some follow-up data, and following you in the background as well, like linking to cancer registries, something you won't be aware of, but it provides follow-up information. So I think, yeah, that's my short answer, or shortish answer to that.
Thank you. Jennifer, how can participants use the information from research findings, for example, COVID-19, to protect their personal health?
Yeah, I think this is a great question. And to be honest, even as a scientist, this is something that I think about personally as well, and trying to wade through all of the information that's out there. And I will say I do encourage a bit of a critical eye would probably be my first response, just because you want to make sure that what you're looking at is not necessarily a one-off. I think that's probably the biggest thing, is that, you know, no one study can really tell us what we need to know, or if there's patterns there. You need to see, you know, the messages recurring over time. And the other thing I look for is when they did this study, were the people similar to me? Because if it's in a totally different age group, or in a mouse model, for example, all important information to contribute to the bigger picture, but what are the elements that are similar to me? So would this apply? And what can I glean from it that would be, I think, reasonable? So the reason I say that is because I'm going to pick on diet and physical activity because that's my area. If we're talking about whole foods, right, and we're looking at, say, the red meat, fruit and vegetable intake, that's sort of at the broad level. I can say, okay, maybe I should be eating less red meat, or when I do, I should have a salad on the side. But when we're talking about very mechanistic things, and we're seeing, you know, say, really specific markers that may predict a disease, I think that's super important to contribute to the bigger picture, but it may not be enough information for me to know, you know, what to do with that right now until we build out what that looks like more broadly. And I think the final thing I would say is just take everything with a grain of salt, and remember that more is not necessarily better. I think really I see this a lot with diet and physical activity. If we show that, you know, say eating carrots is beneficial to you, that doesn't mean you need to eat 3 pounds of carrots a day. You know, it's not going to give you more benefits. So take the broad view and take a critical view, and see how that can apply to you. So I hope that helps.
Thank you. And Guillaume, a question for you relates to, will biological sample collection be resumed? Are there any plans for that, and what would you recommend?
I think we've learned a lot through the pandemic. Obviously, that imposed some logistic issues. So I certainly hope that we will be able to resume those collection. But as I said, we've learned a lot, and what we've learned is that we can do very stellar science even without having to sample biospecimen in person.
Thank you. Now, we are at time. In respect of all of the participants who have joined us today, I thank all of the speakers, but I think all of us as speakers and staff for CanPath, we applaud all of the participants as well. Again, thanking you for your tremendous support, your great interest today. As I mentioned, we will summarize the dialogue today, be making it available through the website. And then I think this can motivate further cross-Canada dialogue like this in terms of helping us frame how to proceed in the future. with the support and the great ideas that you've got, the lived experience. It's very important. There are just so many questions. Maybe just two small points because they're quite germane. One is people have asked about expanding to include First Nations, Métis, Inuit people. That's an area of great interest for health across Canada. We as a team have been working for really a few years, many years now, in support of Indigenous communities, leaders, organizations, and scholars to ensure that this type of prevention-oriented health-promoting research can be done to benefit the Canadian Indigenous peoples, and that work will continue. And then finally, people have asked about how they can access our publications. Again, go to our website. We are trying constantly to ensure that we're publishing in open access form. So if you see it on our website, you should be able to link it and read it. So that's a commitment as well. There's much more dialogue ahead. I would like to thank, again, the speakers today, the organizers, Megan, who's you met at the very beginning, the translating staff in the background. I thank everyone. And then I do look forward to the next time we get to speak. So thank you all. Bye-bye.